An evidence-based, theory-driven resilience intervention for the primary prevention of PTSD. Ladies and gentlemen, please welcome Dr. Petra Skeffington.
Okay, good morning, friends. I'm not a very good academic because I think what we're supposed to do is have a 15-minute presentation with about half-hour slides. I've got a half-hour time slot with about 15 minutes worth of slides. So don't worry, I'll still talk for half an hour. I'm good enough at being a doctor for that. So to start with, I'm going to tell you a little bit about how I got to this topic. This research that I'm presenting was part of my PhD program of research. Before I started the PhD, I was working as a psychologist. I had done some work with VBCS, with returned veterans and their families. And my first master's thesis was trauma-related as well. And so, like any good psychologist, I was like, what's next? I put in a PhD proposal about additive gains in treatment, how we treat PTSD. And so I was writing my candidacy proposal for this, which we all know means I was on Facebook a lot, and I was just reading other things. One of my other interests is positive psychology and resilience, so I was reading a lot around that. Because I got the guilt, I thought, well, I've been reading a lot of this positive psychology stuff, where does it relate back to PTSD? I'll tie it in, I'll make myself feel like I was productive today. And so I started looking, what do we have here for PTSD? And I looked, didn't find anything. After about a week of looking and still not finding anything, I went back to my supervisor and said, hey, I haven't been working on my proposal because I've been looking at this and I think I've got a new question. And this is about what do we have for primary prevention for resilience against trauma. And so that's where this project came out of. Also, I am unclear about how many clinicians or academics or otherwise we have in the audience, so I'm going to try my best just to keep it fairly simple and not too technical. I will fluff it up sometimes and I'll get a bit more technical. My apologies in advance. Usually, I'm used to a smaller room and a smaller audience, so usually I'd invite you to yell at me or to ask your questions as you go if I've not been clear. That's probably not workable here. But at any other time, if you see me around, more than happy to have a chat. If you see me later on my phone, just please rest assured. September is a big month in my religion, and this afternoon at my cathedral in Subiaco, the Fremantle Dockers will be playing the Sydney Swans. So I'm wearing purple in honour. So if you see me on my phone after 3:20, I'm just checking the footy scores, don't worry. You can interrupt that. Okay, so our current practice, for the most part, is that something happens to people and then we deal with it afterwards. When I first was telling people I want to work on primary prevention, I want to work with people before they're exposed to trauma, a lot of my friends laughed at me and they were like, oh, how are you going to get ethical clearance to traumatise people? It's not right, HREC will never clear this. This is a really common view, that the nature of trauma or emergencies or crisis is that we don't know when it's going to happen, it's unexpected. My view is, no, actually, we do know a lot of the time. We have what I would call high-risk professions. We have soldiers, we have fire and emergency service workers, we have police, we have AMBOs. We know that they're going to be exposed to something. And so this something happens part, that doesn't have to be the first step. What we have evidence around is that this is what we do. It's a screen and treat approach. Something happens to people, check in with them afterwards, see if they're okay. If they're not okay, apply a treatment. I don't suggest that we get rid of that. I think we should still do all of that. I would still like to work as a psychologist, so I think, yes, I want to apply treatments for people, but we can do a little bit better. So, also I talk ahead of my slides because I don't follow them very well, sorry. What I noticed in the resilience research, this was in 2011 when I was reading it, resilience research is really broad and it's not targeted at preventing pathology. Resilience is a key word at the moment, right? Everyone's got this buzz for resilience. Resilience is the new black, it's very fashionable. I've got to tell you guys, we don't know what it is. So we don't have measures with strong psychometric properties. We will all talk about resilience, but if I say to you, what is this? Richard Bryant had a slide up yesterday with the graph, and we have those people along the bottom that just stay well the whole time. That graph said to me that resilience was an absence of pathology, an absence of problems. I think resilience is probably a process. So it's different. You can have a mental health problem, you can have symptoms, but you can also be a resilient person, and you can also have a process that you're going through. What you notice if you ask people about their resilience programs, if you read the research, is that the approach, or what I could gather from reading the academic literature, the approach was, well, it feels good. Let's make a resilience program. Let's put in some CBT stuff. Let's put in, give them a box of kittens, everyone likes that. Read a book. The shortest program I saw was about 8 hours long. The longest program out at that time was over 40 hours long, which really did just include everything apparently that people could think of. What I couldn't find was someone who was saying, here's a framework for how we think about resilience, here's how we define what it is, and here's a program that we've applied and measured. We still have a bit of an absence of this, and anyone in the resilience field academically will tell you that. In WA, and probably nationally, there's also a political call for primary prevention efforts. So in 2012 in WA, we had a government white paper released, which was telling us how poorly we were doing with all of our first responders, our fire and emergency services, our cops, our AMBOs, and that we need to do more. And what is starting to develop is this idea that if you know your employees, your members, are going to be exposed to potentially traumatic events, then the organisation becomes liable for their mental health and should be trying to prevent mental health problems. It's an interesting thing to be liable for because we have no evidence that you can prevent them. Not in a primary prevention way, not in a resilience research way. So this is where we were in 2011. We had no primary prevention research, and the interventions that we have are around secondary and tertiary prevention. So something happens, what do we do for people after that? Oh, sorry, I also do want to qualify this for defence people. I'm aware that there are programs happening with defence. We have Battle Smart, Battle Mind. You guys have been doing this for some time. The tricky bit for someone like me, a civilian girl sitting in her uni office, is that the nature of defence is that we don't publish results. And trying to give your defence force an edge through a resilience program that you're trialling doesn't work if you then share that with the entire world. So for anyone that wants to come to me later and give me those results of what you're doing in defence, would love to hear it. This is based on what me or anyone else can get via Google and your search engines. Okay, so this is what I would like to see. Something's probably going to happen. How do we get strong? How do we prepare for it? Then something does happen, and then sure, we will still come in afterwards. So to start, I had my casual week off with a bit less Facebook than I'd liked, but trying to look for the primary prevention research, and I couldn't find it. I wanted to be absolutely sure that it wasn't out there. So I did a systematic review. For anyone who's not an academic, systematic review involves you doing a really broad search of the literature and reading all of the papers until you lose the will to live. So this study, which I call Petra's Summer of Fun, was I went through 15,000 journal articles, that referred to trauma, resilience, prevention, anything. I went as broadly as I could. Had days off for test matches, obviously, I think that goes without saying. Because I wanted to make sure, if I say I'm doing something new, am I doing something new? What I found there was really broad. What people were doing was varied. I couldn't understand the framework, the approach that they were taking. It wasn't being articulated. And there were no thorough randomised control trials. There was no robust research in the area. In fact, most of it kind of looked like, we told people about trauma before they went on this deployment, and then just by chance, we gave them a questionnaire when they came back. So it's, in research terms, it's really not good enough, not enough. As you might expect, skills building is more effective than psychoeducation alone. What I hear from some people saying they're doing resilience interventions, what they're doing is giving people education. It's important to know what PTSD is, but knowing that doesn't give you the skills. So my next step was, I was like, okay, there are no randomised control trials out there, there's no robust research there so far. What do we need? I thought that we needed a program that had a clear framework, where you could follow what was the logic of how this was developed, and it needed to be tested. So I looked at the etiology of PTSD as a disorder, so how it develops, what things people do or don't do that feeds into the symptom clusters of this as a disorder. And I used that as the basis for building a program that hopefully would interfere with that development and stop people from getting PTSD. So what I needed next was a bunch of people who were going to have trauma. There were many options. I didn't know how to choose this, what to do. I was already a fan of some of the work of the firefighters in WA. I was a big supporter of their calendar, and I still am. So I was like, okay, firemen, that's what we'll do. They were also one of the few organisations that agreed to work with me, which is another issue that we have. We've heard from other people speaking about that Defence knows about PTSD, Defence funds this, Defence has programs around it. But when we go out into the community, to talk to our first responders, people are not acknowledging this as much. And so it's very difficult to get into an organisation that will give you time just to work with their people. It was an uphill battle. So, yes. So this is the program that I wrote. It's called the Mental Agility and Psychological Strength Program. Because I've got spare time, I'm going to flesh this out a bit more for you guys. Basically, at this time, we know about mental health issues. There is a conversation about mental health issues, generally in the community. It's not like it was 20 years ago where people didn't know what this was. I was going to work with fire and emergency recruits. They know what it is. They've heard of PTSD, they've heard of depression, they've heard of anxiety. They know all about it. They also know who gets it, because who gets these things? Somebody else. Not me. That guy, someone I don't know. And so we go in to talk about mental health, and what happens? You say, okay, let's talk about trauma, let's talk about PTSD, and everyone switches off. Say, oh no, that's cool, I'm not going to get this. Someone else gets it. A lot of my approach was just saying, how can I rock into a room and have these people pay attention to me? What do I have to do? And so that really was the underlying basis for this. I wrote a program that was framed as a strength program. I don't talk to them about trauma, I don't talk about PTSD, I don't really talk about mental health issues. I talk about, hey, you guys going okay? You're in recruit school, you've just been screened in, everyone's fine, no one has symptoms at this stage. What do you do to stay strong? What do you do if you want to be psychologically stronger? How do you do this? And what are the things that you might do that will undermine your psychological strength? And how do you avoid those? And so there is some psychoeducation in that. There is talk around what happens, if you notice some symptoms, what's that about? If you notice them in someone else, what's that about? What do you do? But a lot of it is about self-care. How do I know myself? What things will tip me off that I'm not coping very well? If I'm in a situation where I'm not sure what to do, how do I take a moment to take a step back, to assess my situation, to plan my response, so that I remain psychologically strong? This reframes things from who becomes unwell, not this guy, someone else, to who would like to be strong. Yeah, most of them do. So that's how I ninja my way around all the psychological tricks to get these people to pay attention. And a big factor in this is social support, of just looking at not necessarily emotional support, not necessarily counselling, but who's around you. In different situations you need different kinds of support. Sometimes, you go, oh, I need to move a couch up some stairs, and I ask someone to help me and they ask me how I feel about that. They're not a helpful person. So it's identifying what it is that you need and how you get that. Another message that we've heard a lot, mainly yesterday but also today, is this parallel between physical health and mental health. We all know what to do with physical health problems, and we recognise this. This was an ongoing theme that I ran throughout the sessions as well. That we can say to people, oh, okay, I've been to a job, I've hurt my knee, what do you do? Everyone knows what to do. Rest, ice, compression, elevation, I could do first aid at home, good. A few days later it still hurts, what do I do? Everyone knows what to do. Go to the doctor, go to the physio, do what you have to. If I hurt my knee and it's painful for 6 months and I'm just walking around on it taking painkillers, do I expect to go to the physio and get that sorted within 4 weeks? No, every recruit can tell me, no, you've made it worse. You've walked around on it for 6 months, you're in pain, you're not going to have a nice tidy treatment, now it's going to take longer. So I want to say this, okay, we went to a difficult job, you're having trouble sleeping. What do you do? What's your first aid plan for yourself? How do I manage this? Where's my self-care? And so we fleshed that out. Okay, what do I do? A couple of weeks later, a month later, I'm still having trouble sleeping. I'm feeling really agitated. Or, I don't know, I have a shorter fuse than I usually would. What do you do? You take that problem somewhere else. Do I talk to the chaplain? Do I go and see a psych and take that there? That's the point in time that you want to go. Same as the physio. You want to go early, you want to get it tidied up. If I'm having nightmares or any other range of symptoms, and I leave that for months or years, do I expect to go to a psychologist and to get that fixed up, nice and tidy, no problems? No. Then you exacerbate the injury and you start to feed into some longer term problems. So this is the framework in which we talk about it now with the fireys. There are people there in WA who routinely go once a year to see the psych, just as a checkup. And I've heard other people speaking about this as well. It's a self-care strategy. I guess it's apparent from what I've been saying, but one of the other angles on this is that we want to remove the barriers to help seeking. Something that I notice, probably in defence, but across all of these professions, is that we have resources. We have treatments, we have psychologists, we have funding, but there's a gap between the people that need that help and them accessing that help sometimes. And so there's something off about that. So part of the theme in this course that I wrote as well is just normalising it. This is what you do. If you have a physical injury, you're going to go to the physio, go to the doctor, that's how you treat it. And if you have a psychological injury, you do the same thing. Hopefully also, by me being there, they had some contact with a psychologist now, and they kind of saw, oh, not so scary. It's okay. All right. I had something else to say about that, but it's gone. That's good, because it will keep us on time. Okay, so what I did. So I went into the firefighting recruit school at the Department of Fire and Emergency Services, and I had 75 of their bright young firemen, and some women. This was a randomised control trial where 31 people got the intervention, so my program. This program was 4 hours long, so I turned up for 4 one-hour modules throughout their recruit school training. I will point out it was written to be 8 hours long, but it wasn't possible to get 8 hours in their recruit school. So this is one of the real constraints that we have with this kind of research. 46 people got training as usual. So that's all the regular training that you want your firemen to have. How do you put out a fire? Put the wet stuff on the red stuff, I believe, is the essence. So, and they received 1 hour of psychoeducation about PTSD, which was the standard. And so I followed these people up for their first 12 months on the job. I had a bunch of hypotheses, which are all fascinating, but we won't dwell on that. Oh, well, actually, what I wanted to find, or what I was measuring, was PTSD symptoms, depression, anxiety, stress, and I was also taking some measures of what coping strategies they were using and what social supports they were using. So these are the things that I'd hoped to influence. What I found is that the group that received my training knew more about the training. That's not groundbreaking stuff. The people who did not receive the training, they really didn't know very much about it. That was the only difference that I found between these groups at 12-month follow-up. These results will be published soon. If you want it, there were more stats. I did more than this. I just don't like putting stats on slides. So, I mean, the obvious answer here is that this program didn't work. But let's just settle down. I've got some other ideas about what might have happened. The obvious idea, if we bring our common sense into this, is that if in the first 12 months of being on the job, a significant portion of recruits were becoming unwell, you know, that they were getting over cutoffs in screens for PTSD, depression, anxiety and stress, I would not be doing this research now, it would be done. It would have been done years ago. We know we don't screen people who are symptom-free and then 12 months later have them all falling over. So really, you don't expect to see an effect of this kind of program within 12 months. One of the controls did get PTSD in that time, but that's another story. It was not significant in stats land. A bunch of other reasons that this may not have worked: insufficient power, that means that just not enough people. Ineffective dose, that means I wanted 8 hours in the recruit school and I got 4, and maybe that's not long enough. I might have put the wrong things in the program. You know, fair play, I'm pretty good, but sometimes I get it wrong. Issues with measurement. One question that I get asked a lot is, why didn't you measure resilience? My answer is, if you can tell me what that is and give me a measure of it, then sure. Issues with time span, I think, yeah, that's the big one. 12 months is not enough. The next follow-up planned for these participants is at 5 years. I'm still unsure whether we'll see an effect within 5 years of whether enough people would be expected to become unwell in that time. This kind of thing, it's a cumulative stress type job. 10, 15, 20 years, I think, is where the effect would be, if there is one. I did have an idea that maybe normalising everything and removing the barriers to treatment seeking reduced masking of symptoms. Something that we know in this kind of research in the high-risk professions, especially male-dominated professions, is that everyone lies on their screens so that they look like they don't have symptoms. Or I think the tactful way is to say we underreport. So maybe everyone was being more honest. I don't know, that one, I have no evidence of that. I'm drawing a long bow now. So for the future, I am looking at making some changes to the program, looking at different ways that we can intervene that have more of an evidence base, particularly given the short time that we have with recruits. The program as it stands is continuing to be delivered in recruit school, so I was hired on as the resilience training officer at DFIS to continue to do that. We do need a longer follow-up. Of course, I would use different measures if I'd thought of it, but in 2011 I just wasn't thinking that way. It's reassuring when you get a degree that you go, I did learn stuff because now I know all the mistakes I made and what I'd do differently. So I learned a whole lot of stuff about mistakes that you make. A big thing for the future is addressing the practical barriers. How do we get organisations to prioritise this? And how do we get invited in to have time with recruits or time with people at other levels in the organisation, at other ranks? As with any trauma research, and as we've learned from debriefing research, which again was something that had a little bit of evidence that debriefing could prevent PTSD, we had a whole lot of push because of organisations being liable. And so we rolled out debriefing for everyone and actually made people worse. So it's very appropriate, I think, to consider that maybe recruit school is not the time to do this. I had to make this a primary prevention program because that's how you get a PhD. It's got to be a unique contribution to knowledge. Now that that's done, I would be considering maybe at recruit school, maybe in your initial training, that's when you should be learning how to put out fires, how to go to motor vehicle accidents, how to become competent in your job, which by itself will act as a protective factor for you. This kind of training is perhaps just not appropriate at that time. We don't want to interfere with people learning how to do their job. So that's on the back burner. I'm talking with DFIS about it, about where else we might come in to give people this kind of intervention. All right, that's it for me. Please email me, talk to me, anything you would like, and thank you for listening.